Good morning, and thank you for joining us for this timely and important virtual conversation hosted by PolicyLab and the Poison Control Center at the Children's Hospital of Philadelphia. I'm Radha Panati, the Policy and Strategy Manager at PolicyLab, and in this role, I provide leadership for our adolescent health and well-being portfolio in the implementation of our evidence to action model. We come to this conversation with our partners at the Poison Control Center amid a changing clinical and state and federal policy landscape. Poison control centers around the country are fielding a rise in calls related to children's ingestion of marijuana-derived products containing tetrahydrocannabinol, or THC. This rise in ingestion of THC is in part due to the increased availability and potency of products containing THC and limited state activity related to safeguards to protect children. The policy environment is dynamic as well. At the federal level, a proposal to reclassify marijuana from a Schedule I illegal drug to a Schedule III drug is being considered. And across the country, state policies on legalizing medical or recreational marijuana and decriminalizing marijuana continue to evolve. There are many dimensions in this changing clinical and policy landscape. Today, we'll be focused on how we can consider children in these conversations. Our panel will discuss research on THC in youth, practice considerations, and the increasing availability of products in the shifting policy context. This conversation is focused on non-medically supervised use of marijuana, and it is not our intent to offer a position on state policies regarding legalization of marijuana, but rather to discuss what the research tells us on how marijuana policies affect children and youth and what we can learn to minimize injury of children as THC products are more widely available across the U.S. Each participant offers their own individual perspective. A couple of reminders for those listening in to today's presentation. All attendees' lines will be muted and video will be disabled throughout the event. We're looking forward to a robust discussion following our panelists' opening remarks. So if you'd like to submit a question, you can do so at any time during the event using the Q&A feature located on the bar at the top of the platform. My colleague, Dr. Terry Randall, an attending psychiatrist in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at CHOP, will moderate today's event, and I'll turn to her to set the stage for the discussion. Welcome, Dr. Randall.
Thank you, Radha, for your introduction and your opening remarks. I really thank you for this opportunity to participate in this discussion because, one, it's timely and it is a really dynamic landscape that we're facing at this time when it comes to cannabis and the laws. And now we have this opportunity to think about how it's impacting our youth. As a fellow New Jerseyan said, the children are our future. And right now we have the opportunity to really think about how we develop that future, how we protect that future. So thank you. When we think about cannabis, a couple of things I just wanted to kind of set the stage. When we're talking about the cannabis plant, it is a plant that has over 400 compounds within it. The compound that we're usually referring to is delta 9 tetrahydrocannabinol, or THC. That is the compound that has the psychoactive and euphorogenic or high effects when someone consumes cannabis. There's also another compound that people may be really familiar with these days is CBD. Seems to be in whatever and kind of touted, I say, as the new fish oil, good for whatever ails you. Another compound that people may come across is delta 8 THC, which is thought to be a more mild form. And another term that you might hear of is hemp, which is the same cannabis plant, but it has a much lower THC content of only 0.3%. So that's a little bit of the lay of the land. And when we think about the youth who are impacted by these changing cannabis laws, we're really thinking about, one, young children who often may find it, see labels that look like candy and ingest it, and we'll be speaking more to that. And then we also have our adolescents who may start to experiment and who are at risk for developing mental health and physical health adverse effects of their exposure to cannabis. And really weighing the risks and benefits and being thoughtful and data-driven is a great opportunity that we have to explore during this conversation. So let's jump right in. First, we have Dr. Jesse Hinckley, assistant professor at the University of Colorado School of Medicine and a practicing child and adolescent psychiatrist. Next, we have Dr. Frank James, the medical director for substance use and addiction services program development in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at CHOP. Dr. James has previously had a role on the board of directors for the American Society of Addiction Medicine. And last, but certainly not least, is Dr. Kevin Ousterhout, a medical toxicologist, attending physician in the CHOP's emergency department, and the medical director for the Poison Control Center at CHOP. Thank you to each of you for joining us today. So Kevin, let's start with you. Following Radha's introduction to this topic and mentioning about the impact that this has had on the poison control centers, can you tell me about what's happening and what you're seeing and what the data is about THC in very young children?
Absolutely, Terry, I can tell you our data right here from Pennsylvania where we're sitting, and it's interesting. My perspective has grown as a pediatrician and as a pediatric emergency medicine provider working in the emergency department, and as you mentioned, at the Poison Control Center. And it used to be marijuana and THC was about the most boring thing in my career, and we never ever talked about it. And when I went back to 2015, right, almost a decade ago, and I looked at the number of cases that my poison center was called about from the state of Pennsylvania and Delaware, in 2015, it was 4, okay? In 2019, it was 27. In 2023, it was 332. And in 2024, it's even bigger than ever. So it is now every single day, we're getting a call from Pennsylvania and Delaware about a child under the age of 6 who has become exposed or injured in some way by THC products. And in this world, what we see is it's almost entirely attributable to edibles. And depending on the data source that you look at in published series using different databases, we can see anywhere from 5 to 25% of these children actually being hospitalized in intensive care units, somewhere from 1 to 10% of these children being put on ventilators or breathing machines to help them breathe. We see descriptions of movement-like disorders that people are calling seizures, coma, and many other health effects like that. And so as a person who's really interested in child injury and child injury prevention, it does seem like a place where we can have some impact with policy.
Wow, that is a really remarkable increase that you described. Just curious as a follow-up, have there been any deaths?
That's really interesting data to consider, Terry. We see clear evidence of respiratory depression from blood gas analysis of children who are in emergency departments and in ICUs. But it is actually very hard to find a child who has died from acute overdose in the way that we think of it with things like fentanyl and heroin and drugs like that. There are scattered case reports. A group of toxicologists using a database they call Toxic just did a report of children with severe THC injury, and they report 1 death in that database, but they don't provide many details for me to really kind of referee it and know how real that is. There have been some legal cases that have appeared in the news and in court of child deaths due to THC or marijuana, and there have been several cases published of children with actual unusual toxicities of cardiac toxicity and what we call myocarditis that they have related to THC. And so I think we need to do a lot more critical look at the data to see how deadly it is, but we certainly know that it is putting children in hospitals, putting children in intensive care units, and causing both a lot of a lot of fright for families and stress for families, a lot of intervention for children, and a lot of healthcare dollars.
Absolutely. Well, thank you for that. And I wanted to move on to Jesse. Um, what, um, some information about, we're talking about two age groups, young children and adolescents. Can you talk about your research on addiction, changes or trends in marijuana among youth more broadly?
Yeah, happy to. And thank you for the opportunity to be with you all today. So when we talk about adolescents, I think traditionally we think of the kind of like the 12 to 18-year-old group. I would encourage a broader thought process of, really kind of 12 to 25. 18 is a legal cutoff, really has no data behind it. If you've ever hung out with a 19 or a 20-year-old, sometimes the 17-year-old is a little bit further along in their development. So, but just thinking about it, when we're talking, and the reason that's important is because when we're talking about cannabis in particular, the big thing that concerns us with adolescents is brain development. Get one shot at that, and the potential impact on brain development is the biggest risk. So when we talk about, well, what's the impact of legalization? The simplest way to answer that question has been to look at prevalence of use. So in the last year, in your lifetime, in the last 30 days, those kind of questions. When you look at 12 to 17-year-olds, over the last decade of legalization history, there has not been a rise in the prevalence of cannabis use, which has led to a lot of people pointing and saying, well, see, it doesn't have an effect on teenagers, which is only part of the story. When you look at the 18 to 25-year-old population who's still going through brain development, the prevalence rates among that age group is increasing and has increased sharply. And that those rates of increase are higher in states with recreational marijuana laws than states without. So that's part of the story. The other part of the story is, what are they actually using? So there's increased access. Perhaps one of the greatest impacts of legalization is commercialization. And when you commercialize something, you have an ability to produce it and, for lack of a better term, produce a higher quality product. For cannabis, one of the measures of quality, which is probably misapplied, has actually become THC concentration. And so there's this perception that the higher the concentration of THC, the better the product. And so now we went from having products that on average were 4 to 8% THC for blunts in Colorado now to 25%. Concentrates that used to be between 30 and 40% are now routinely 95% THC. And so that's a huge difference in terms of what youth have access to. When you look at the effects of it, there are some effects that I think are relatively unique to youth that are concerning to me as a provider. One is its effect particularly on mental health. So when we look at the data, there are some unique signals around psychosis, around suicidal ideation and suicide attempt in youth that are particularly concerning. When you look at the early data around psychosis, high potency in those studies was 10% or higher. And now pretty much everything is above that. So we really don't have high quality data on what's currently available in the market. We used to see, initially we first saw more kids coming into treatment earlier on. That's actually tapered off, and now Colorado and Washington have fewer kids coming into treatment for cannabis use disorder. And part of the thinking behind that is because it's become so normalized. The perceived risk has gone down. People look at this and go, it's legal, it's natural, it's not really a problem. And so we've actually seen what used to be more youth coming into treatment now actually turning around and going down. And so lots of challenges there. And then when you play catch up in a regulatory capacity, we're running into barriers of, well, you don't have data. You can't show that this is a harm, or you can't show what potency or what concentration is safe or not safe. And so that's led to challenges protecting youth, because a lot of time those data take years to collect, and some of those studies are extremely challenging to do. So I think it has had a much bigger impact than what we maybe see on the surface, because a lot of the times we're focusing on that one question rather than a bigger picture of what's actually going on for youth.
Thanks, Jesse. Really struck by what you're seeing in Colorado about teens presenting for treatment. Being that most teens do not self-present for treatment, what do you think that has to say about not only youth perception of risk, but also the general population or parents' perception of risk?
Yeah, that's a good question. So I would say a couple of things. One is it's not all that common that youth are going to present for any substance use disorder and say, I have a problem with substances. They tend to view it a little bit differently than that. They're more likely to enter the system for mental health problems or for other related issues, and then it's providers helping them connect the dots and helping them realize, well, I wonder if the reason your anxiety is worse, if the reason your depression's worse, is because of X, Y, Z. And then a number of them will access it through the legal system. So they get in trouble at school, they get in trouble with juvenile justice, and they get sent to treatment. Unfortunately, in the United States, being justice involved as a youth is like the one positive predictor that you're actually going to get substance use treatment, which says something about the system in which we work. It's kind of a sad system in some ways. In terms of working with families, there are real barriers there. So we will have youth come into treatment usually because someone else told them they had to. And then the parent will say, well, I smoked weed when I was a kid and I turned out just fine. And that might be a debatable statement, but that's not worth getting into it with the parents. But the thing that I would say there is the 2 points I try and make is, well, one, cannabis is different now than it was then. And two, we're talking about brain development. And I think we can all align around the fact that we want your youth to have the best chance of growing up. At the end of the day, there are going to be youth who are going to use cannabis and they're going to have no problems related to their use. And that's just kind of, it is what it is. And then there are going to be youth that use cannabis and they're going to have problems related to it. And just like some youth have diabetes or some youth has asthma, it kind of becomes an is what it is conversation. So what are we going to do about it?
Thanks, Jesse. That's information you shared with us about that. Frank, now over to you. Jesse mentioned problematic use among youth, all different levels and types. I know some of your work is around cannabis use disorder. Is that even a thing? I know that some people even debate whether that there is a potential to become addicted. Oh, I think you're still muted.
Great questions, Terry. And actually, Jesse, thank you for teeing this up for me, because going from the research to my experience as a clinician, the statistics actually are very helpful and they come to real life when we see patients. So Terry, I actually want to tackle that question in two parts. So the first, let's look at cannabis use in adolescents in general, and then second, I'll address cannabis use disorder in adolescents specifically. So there are plenty of statistics to demonstrate that there's a problematic use of cannabis and its related complications with social and academic, general health and mental health of adolescents. And I'm going to briefly mention ones I believe provide a good context for our discussion. Now, first thing is, the good news is that most youth are not using drugs and alcohol. So despite kids been saying, well, everyone's doing it, that's actually not true. Most are not using drugs and alcohol. But the unfortunate news is, for those that are using, marijuana remains the most used illegal substance among youth. Now, I actually came to Philadelphia from Colorado recently, and when I left, cannabis use exceeded tobacco use in adolescents. But a few statistics on use. The first is, by the time they graduate from high school, about 45% of US teens will have tried marijuana at least once in their lifetime. And according to the National Institute on Drug Use, about 1 in 14 teens say they used marijuana in the past month. And merely a decade ago, about 22% of high school seniors reported current use of marijuana and 6% daily use. So those statistics actually appear to be worsening because of the advent of vaping. So Jesse also mentioned, while other substance use like alcohol and nicotine, has declined over the past few decades, the prevalence of cannabis use has remained steady amongst adolescents, but it's actually creeped up a little bit in young adults. So just a couple of caveats about prevalence. Although its prevalence is lower with adolescents, opiate use is very concerning due to its increasing mortality rate. So we can't talk about cannabis without at least mentioning opiates. But second, even though the prevalence of cannabis use appears to have remained steady amongst adolescents, like Jesse mentioned, the potency is what we're concerned about. So anyway, why are statistics important for us? So I think that, as mental health professionals, it's important that we educate our patients and families about the consequences of all illicit use of alcohol and other substances. But because the prevalence of cannabis use amongst teens exceeds even that of cigarettes, it's important that we also educate teachers and policymakers, government officials, and other professionals about the consequences of cannabis use. So anyway, now to your question, Terry, and the question that most parents ask and the answer that most adolescents deny: can cannabis use lead to a cannabis use disorder? And the short answer is yes, it can. Anyway, so terminology is important and it's clinically relevant. And so I also think that terminology can be a little bit misleading. But let's review a little bit of that now and talk about terminology specific to cannabis use disorder. So we have abstinence, which means no use. We use the term regular use, and that describes use with peers, like in low-risk recreational situations and occasional weekend use with friends. Then there's problematic use or problem use. That's use that causes disinhibition and the kind that often leads to harmful consequences, like driving under the influence. And then we talk about disordered use. And when we see disordered use in adolescents and adults, we usually see three or more things. Usually we see kids giving up important activities with friends and family in favor of using drugs and alcohol and cannabis. We see continued use despite negative consequences. They develop tolerance, withdrawal symptoms when it's not available, and most significantly, trying but failing to quit. So now, most youth who engage in substance use do not really reach the problem use. But in my clinical practice and the kids that I treat, any use is problem use, especially with cannabis. And although we differentiate between regular and problem use from disordered use, we forget that any use during adolescence needs intervention before developing use disorder. So a few statistics about substance use in general. So most substance use begins in teenage years. The second is the earlier the use, the greater likelihood of developing a substance use disorder. And the third is 90% of adults with a substance use disorder say they started using drugs and alcohol as teens. So in general, overall, 5% of adolescents ages 12 to 17 and 15% of young adults ages 18 to 25 meet criteria for a substance use disorder. But specific to cannabis use disorder, approximately 3 in 10 people who use marijuana have a cannabis use disorder. That translates to around 4 million people ages 12 and older. But what I think is most important is that 17% of adolescents who even try cannabis will develop a use disorder. And that's nearly double the amount of people who develop a use disorder as teens compared to when you use marijuana for the first time as an adult. So I'm going to leave you with the last statistic, and that is the risk of developing a cannabis use disorder increases when use starts early and when use is frequent.
Oh, thanks, Frank, for sharing that information. That I'm always struck by the real difference and the sensitive period of brain development for adolescents and how they are at really increased risk for developing cannabis use disorder or any substance use disorder when they have that exposure in that early period, as opposed to that the adult fully formed brain, as you mentioned, and really the difference that comes with starting use in adolescence versus when the brain as finally developed. I also just wanted to also note that there's also impacts on the physical health as well. There are impacts that we see on cardiovascular and the pulmonary system. There's an increase, what we see a lot more in the hospital. Kevin, you can probably speak to this too, is a lot of the cannabis hyperemesis syndrome that has been much more prevalent, I think, with these higher strains as well. I'm not sure if you're seeing that in Colorado too, Jesse.
Yeah, definitely. That used to be fun in like 2014 to 2016 as we would go to conferences or get on calls with people and they would describe these gastrointestinal cases of cyclical vomiting, and they do like the $1 million GI workup and not get an answer. And then one of us from Colorado would just raise our hands and say, "To hot showers help?" And they're like, "Yeah." I'm like, it's we know what it is, because we probably had at least one person admitted at all times to the hospital. And so, that e-vaping associated lung injuries, EVALI, or e-cigarette and vaping associated lung injuries in 2019, we definitely had cases of that in Colorado, and that uniquely affected youth. We talk about the effects of smoking, and we're like, oh yeah, old people with COPD and cancer. But the injuries that can result from vaping can be acute injuries, and so they can happen to people that are otherwise healthy. And we talk to youth about, hey, if you're going to vape, you got to know where you're getting your stuff from. You can't be getting these black market or home chemistry set type pods and vape juices. There are risks associated with this that are real for youth. If I can, I wanted to add one thing to what Frank said. I think it's important because this comes up in any sort of conversation about legalization of, well, cannabis isn't addictive. There's no substance use disorder here. And part of what makes that challenging is when you look at early research studies, that there are papers that support that. And those papers come from the fact that animal models at the time wouldn't self-administer cannabis like they would heroin or cocaine. In other words, they really didn't eat it. They didn't care for it all that much. However, as it turns out, animal studies have gotten a lot better, and rats are a lot like humans. They really like vaping. And so with the advent of vape chambers, there's now a lot of animal studies that they will happily administer this to themselves. And so I think that's part of the context of the historical statement of there's not a cannabis use disorder, it's not addictive, comes from earlier animal studies where the animals didn't self-administer it by eating it. And so people just wrote it off and said, well, if rats don't like it, then it's not addictive.
Thanks for sharing that. I just wanted to open up, actually, let me just check in with Radha to see if if it's time to open up for questions, or if I have time to ask the panelists one additional question.
I think you have time to ask the panelists another question.
Okay. So in your practice, I wanted to know whether what you're hearing about what parents are thinking about marijuana. When is it coming up? And if you could also link that to how your practice has influenced your view of research and policy and questions that need to be studied.
All right. Well, I'll go ahead and start, Terry.
Yeah.
And again, most of my work is focusing on the younger children. And so picture going to your local shopping mall and encountering a product like this, right? It's got a cute little elf on it. It looks like a favorite little cereal you might have. I have to actually be careful leaving this on the desk here in my office in case my colleague with a sweet tooth decides to come in and think that they would like to eat this. And, this is an unregulated THC product in the state of Pennsylvania. And you have to look pretty close to see that the brand name on this isn't spelled correctly, and that on the back there's a little 7-leafed plant, and that it says 500 milligrams on it. 500 milligrams of what? I'm not really sure, but but even Jesse and Frank shouldn't be taking 500 milligrams of this. So imagine what happens when a 2-year-old finds this and thinks it looks like a delicious treat, right? And so for me, parents are often astounded. We had a parent who opened up her trunk and found a whole bunch of candies in her trunk that she didn't know that were there, but she said, oh, the kids at this birthday party will love them, went out and distributed them to a whole bunch of first graders and found out that somebody else in her family had snuck them in there and they were all THC treats, right? And so we had a whole party of first graders who became high. And so for me, for policy, right, we have decades of poisoning prevention research that tell us we shouldn't put drugs like THC in things that are attractive to children, that are in candies, that are in cookies, that are in brownies, right? We can fix that. We know about child-resistant packaging. We know about opaque packaging. We even know about where we put them in stores, right? They shouldn't be near the other foodstuffs and candies. They should be in dedicated places. And, I mentioned the 500 milligrams. Some great research by Dr. Pepin and colleagues was in Pediatrics in 2023, and they tried to look and say, all right, how much delta-9 THC does it take to cause severe toxicity in a young child? And it was anything greater than about 2 milligrams per kilogram. When you think of your average 1 or 2-year-olds, probably about 10 kilograms, that's when you get to be about 20 milligrams of THC. So why is there more than that in any package, right? And so there are a lot of things that we can think of in policy to help this. And the one last policy thing I'd really love to see is there's big economics in THC and marijuana products. And it would be nice if we could get some of that economic stimulus funneled back to child injury prevention policy and research. So from there, I'll let you go to Jesse.
Thank you. So, we talk a lot about edibles and the impact it's had on youth. Having worked in emergency departments in Colorado and been associate medical director of the psych side of the house, edibles also have their own adventures in adults. There's this phenomenon that we would experience in Colorado where people would come into town for a conference or for a concert. They've never done cannabis before and they decide, well, I'm here, it's legal, I might as well give it a try, but I don't smoke and I don't vape. And so they get edibles and they take them back to their hotel, not realizing that some of the brownies or cookies actually have like 10 servings of what's considered a serving of THC in it. So in Colorado, because of the rash of incidents with unintentional overdoses, they put in place a regulation that any edible product has to be demarcated in 10 milligram intervals at a maximum. And so, but people don't realize that could be one gummy bear, that could be 1/10 of a brownie. So it's not like it's the whole product. And so invariably people end up disrobed at some point running around their hotel, and then they wake up super embarrassed in the emergency department as we have a conversation with them about their first cannabis experience. And so the edibles don't just affect our little ones. In terms of how we see it in treatment, most of the time it's youth coming in for something: depression, anxiety, PTSD, behavior problems. They're coming in for something, and sometimes a parent or another adult teacher, counselor, therapist, believes that the cannabis use is a problem and they think it's contributing. And sometimes, it doesn't even come up, and they make it all the way through treatment and they don't respond to therapy and they don't respond to medication, and nobody really asked them about their substance use because they weren't really going to address it. And so it often can go missed, but most of the time that we're picking it up, it's coming up within the context of what else is going on. Some youth are open to conversations about it. I found that there are very few youth that don't have goals for themselves. And if you can find out what that goal is and help them align around it, they're usually willing to make the changes to help them get to that goal. And so there's a way to get at it. There's a way to talk to them and help them make decisions for themselves. If I come at them and say, hey, I think this is a problem and I think you need to change, I've already lost that conversation. It's not going to happen. And so helping them recognize what their goals are for themselves, align around that, and tie the treatment recommendations back to that goal, and we can make progress. On an aside, Frank brought up fentanyl and opioids. I will say the one thing that I found really interesting in the substance use world is I've had an easier time in the last 2 years getting teens off of fentanyl than I have getting them off of high concentrate cannabis products. And I think that may speak in part to the types of treatments that we have available that don't exist for cannabis and can make it difficult to treat. It really has, especially if you're using high concentrate products, it really has a very notable withdrawal state, and youth don't tend to tolerate that very well, and it becomes distressing for them.
Well, I'll go last, Terry, and actually I'm really enjoying going last, and especially after Jesse. We've never met, but you're teeing me up really well because in my clinical practice, I'm seeing three prominent things, and you've touched on just about all of them. So as you, Kevin. Actually, in my experience, treating all use disorders, I think that treating cannabis use disorder is the most difficult. Now, and for three reasons, and the first one is I'll mention vaping. Over the past decade, there's been a dramatic rise in the prevalence of vaping, and including nicotine and cannabis, and nearly 1/3 of youth report vaping at some point in their life. And Terry, you mentioned physical problems. So physically, vaping cannabis may cause slightly more respiratory problems compared to nicotine. But when it comes to cannabis, as I mentioned earlier, vaping is mostly an issue because of its frequent use and its high potency compared to nicotine. And additionally, the effects of vaping cannabis on the adolescent brain, which actually appears to be the same as just smoking cannabis, they're much more concerning than the effects of nicotine and probably both alcohol and opiates. And Jesse touched on a couple of these as well. The three most significant ones are an increase in schizophrenia, decrease in ability to pay attention, increase in impulsivity, including a rise in risky behaviors and dangerous and violent behaviors. And there are effects on IQ and cognition. The second problem I see clinically is notwithstanding disordered use, but regular use among adolescents and young adults can cause long-term effects on the brain. Now, as clinicians, we often see this as difficulty maintaining attention, memory and learning problems, thinking and problems with problem solving, reduced coordination, and of course, then achieving a satisfying academic and social life. But to the teachers who might be out there, you can probably relate to this, and probably not surprising, that compared to kids who don't use marijuana, teens that do are less likely to graduate, and they're from high school or from college. So, but the third thing is, if you think about this, like I talk about it as the diagnostic complexity. So if you just take regular use and the symptoms that we see with that and overlay those on other behavioral health disorders, it's really difficult for me as a clinician to tear apart those and figure out what's a behavioral health disorder and what's the substance use disorder. And, even if I get the right diagnosis and even if I got some of the right medication, regular use of cannabis makes treatment less effective. And the last thing I just say is that in terms of the research, is that it is really difficult to get good research. One, because even though there's less stigma treating behavioral health disorders in kids, there's still significant consequences to having a diagnosed, documented, and treated substance use disorder. And even amongst seasoned clinicians, I think that we avoid asking questions about things we feel uncomfortable treating. And then compared to their peers, adolescents with a primary behavioral health disorder are 2 times more likely to develop a co-occurring substance use disorder. And so as a result, kids that are receiving medical care and behavioral health care, lack of appropriate screening and underdiagnosis of co-occurring disorders results in worse family, academic, social, and occupational outcomes.
Thanks.
Yeah, that's fabulous. And before you go on, Terry, Jesse, you highlighted this, and Frank, you highlighted it. And I just think it's the really amazing thing is the difference of strength that marijuana is not the same now as it used to be, right? And so, I remember being a teenager and having images of Janis Joplin at Woodstock, and she'd have a marijuana cigarette in her mouth, and it would seem like she would smoke that thing all day long, right? but it was 2% THC, and she could. And as Jesse mentioned, when I looked up one of the recreational dealers in New Jersey near me, most of the products that they were selling were 27 to 37% THC. And then when you get to the vaping that Frank was just talking about, you're approaching 90 to 95% THC. And so a lot of parents bring their kids in who are now acutely paranoid or acutely delusional or comatose and said, yeah, I know they smoke marijuana and this has never happened before. And they don't realize that, oh, they just got this vape pen from this dispensary, and just the content is so different. So it really is a very different topic than it was for us 15 years ago now.
Absolutely. And I'm also struck by just the fact that people, it's very different, the concentrations and the impacts that it has on the brain. So thank you for highlighting that fact. I wanted to think about, this is a PolicyLab sponsored event, so want to think about policy. So if you could wave your magic wand and enact some policies, some federal or state regulations, have some recommendations about how to make some inroads around some of the things that you brought up around packaging, around access. I think around education, parents. One of the other things that I was struck by, oops, I lost it, never mind. But if you guys could just share your thoughts about that, I think everyone would be really interested to hear what you have to say. Let's start it off with, we're gonna go backwards. How about we start with you, Frank?
All right. Yes, this is the PolicyLab, so this is for the policymakers. So, oh gosh. So for the treatment of problematic use of drugs and alcohol in adolescents, I would wave my wand around state regulators and agencies and change the way we license community mental health centers and medical facilities. I would actually like to be able to focus on the needs of the adolescent in front of me. And I want to be able to centralize medical, behavioral health, and substance use treatment in one location. I want to be able to coordinate care for patients, decrease the burden on families and single parents and teachers in schools and governmental and judicial systems like family court and juvenile justice centers. Like we need to stop bilocating, trilocating, and quadrilocating services for kids. You get your medical care over here, you get your behavioral health care over here, and you get your substance treatment, if you're lucky, over there. And so, like what family has time and what agency has the money and the manpower to travel all over the city to get care for our kids? And Jesse mentioned earlier, like statistically, we know at the end of the day that treatment for substance use gets the short end of the stick. And although this is why kids are more likely to be expelled from school and marginalized in society and incarcerated and even die, they're less likely to get their substance use treatment. And so I would say the magic wand for those that can provide both behavioral health and substance use treatment, as well as medical treatment, allow us to get one combined license so we can treat the patient in front of us.
Absolutely, well said. Let's move on to Kevin.
All right, Terry, I guess I jumped the gun. I gave some of my policy recommendations earlier. One of the things that I would love to do, especially with healthcare providers, public health officials, is have a magic wand that allowed them to all recognize their implicit biases in the way that they perceive patients who have had exposures to marijuana or THC products. I think that our implicit biases often make us treat people differentially. I think that it would be nice if we could develop less judgment and more willingness to help, and to decrease the stigma so that this was something that people could talk about and even mention when you came to the hospital because your child was ill. A lot of parents are actually afraid to say, I saw my child get into my THC gummy, because they think they might get in trouble, and I would love to see that stop. And otherwise, Jesse and Frank both have experience, as different states create regulations on recreational marijuana products, they come up with great ideas, such as there shouldn't be more than 10 milligrams of THC in a unit dose, that it shouldn't be marketed to children, that it shouldn't come in brownies, that it should be in an opaque container, that it should be in a child-resistant container. And I think that we can look at what has happened across the United States, what's happened in Canada, and we can now revise those policies to make sure that we're doing our best to protect young children and the teenagers and the young adults who are being challenged by this product.
Thanks. And Jesse.
Thank you. So I agree with what's been said, and I think this is a challenging question. So obviously legalization is happening and regulation is happening primarily at the state level, and it differs from region to region. So Colorado and Washington both legalized cannabis in 2012. Colorado went first and implemented sales in January 2014. I like to joke around that the other states waited to see what we screwed up so that they would have a better idea of what to do. And I will say, starting from a minimally regulated posture, it's really difficult to put that genie back in the bottle. And so it's extremely important to be thoughtful. The reason that Colorado had to come up with a unit dose and had to come up with packaging regulations is because they didn't put that in place, and they saw a huge increase in unintentional overdoses. And so thinking about this, but also thinking about, we're talking about, and this comes up in regulatory and rulemaking groups, we're talking about adult use. We're not talking about adolescent use. So that's not a part of the conversation. It's like, well, that's not true. Kids and teens, they are part of the conversation. These things do get marketed to them. I don't know of an adult that would choose to vape rainbow unicorn flavored products, but that exists. That's not catered towards an adult population, and it's part of the reason that Juul got in trouble. There was social engineering involved in their marketing that specifically targeted adolescents, and so it is part of the conversation. I think what I would say, though, is there needs to be a shift in the framework around the conversation. Right now, we're fighting against the tide of, well, you don't have data to say how much THC is too much, and so we don't feel like we can regulate that, or we don't have data that it's associated with, enough data that it's associated with cancer, or that it's consistently associated with this outcome, so we don't feel comfortable saying that. I mean, if you look back at how long it takes to get that kind of data, you're talking 30, 40 years down the road. And so, some of these lessons, like, we already know that a cannabis joint has higher concentrations of carcinogens than a cigarette. So do we need to wait for 30 years of data to be able to say, actually, there's a signal here? Because we know the risk factor is still there. We know it exists. We know that the tar deposits in the lung are higher. And so there are things that we can borrow from research that's already been done. But we're saying, well, because we don't have that for cannabis, we can't act on that. And so that's made it a very difficult perspective to work from. And that goes to I know we're not talking about that here necessarily, but that goes to the medical side of it as well. There's not really a medical product that gets sanctioned by any sort of political or government organization, and then there's no dosing guidelines. There's no, how much do you take, how often do you take it, how long do you take it for, and in what form. And that's really, I think, unique to cannabis. And that does cause challenges where people will say, well, it's got medical benefits and it's safe. And yes, cannabinoids do have medical benefits. They've been used for years. And so that's not an untrue statement, but there's a difference between, researched pharmacologic agents and unregulated broad spectrum agents. And even now with hemp-derived products, we're running into a similar issue where it's Delta 9 THC specifically that's regulated, but not Delta 8, not Delta 10. And so we're now running into hemp-derived products where we're seeing similar effects with psychosis or other type of incidents that are happening. And so we had a conversation with the Senate panel that was advising on the reclassification of cannabis. And our advice to them was regulate THC as a group, stop regulating individual compounds. And that's something where we saw the same thing with synthetics, where manufacturers stayed ahead of the government because they would just change the formulation and it would take too long to ban the next specific substance. And so I think the framework, we need to adjust the way that we're thinking about it and how we're approaching it.
I'm going to jump in with a question from the Q&A. I certainly think we've spent a bit of time talking about policy opportunities and the clinical landscape, and certainly there are other stakeholders or folks that are impacted by adolescent use of cannabis. And so there's a question in the chat about how, for example, local educational agencies or perhaps at the state level are engaging or are doing it in states with marijuana legalization in terms of like reducing adolescent use, accidental ingestion, or perhaps even educating around that. Curious across the panelists here if anyone can speak to both what they've seen or what opportunities there might be.
I can speak to Colorado. I think we probably have a little bit more experience with this. So it varies in terms of response. I think one of the things that's been particularly helpful is the educators have made a concerted effort to make sure that kids are not being removed from school, expelled or out of school suspension for like vaping in the bathroom or a minor in possession, and really trying to say, okay, we already know that school connectedness is protective. And so if we know that these things are protective, being successful in school is protective, being connected, having those friends, don't remove kids from that setting where they're more likely going to be successful because they have it. And so I think taking a strengths-based approach of saying what are the protective factors that we can build on has made a big difference. Keeping kids in school, trying to get treatment to them in school and in school-based health centers has been key. And so education, I think, is helpful, but education in a way that's respectful. DARE went away because DARE didn't work. Although I loved it when the drug dogs came to school because I like dogs. And so, but those kind of scare strategies don't work for kids. It's really, but if you can have a really intelligent conversation with a kid and they will make what they think is the best decision for themselves. The most common reason that kids are using substances isn't because they want to get high or because they want to be deviant. There's something else going on. And so if they have access to that education, if they can stay connected, and if we can find ways to build on their strengths, we're going to make a much bigger impact than if we're putative about it and say, hey, you got to go home because you brought a vape pen to school.
Thank you so much for that. And thank you for all of your the panelists' thoughts about these topics. You know, I was really just struck by we have opportunities to make inroads on protecting our youth with things like you mentioned, labeling, not having cartoon characters on products. And I'll challenge you, Jesse. I think some adults probably do like to harken back and think about their childhood and some of those things because they seem so novel and interesting. May attract some people and kind of nostalgia to want those products. But I think on the flip side is really balancing the risks, like having those products distributed to a whole class of first graders. And so is that really worth the risk? And those are the things that we're going to need to think about, especially when we weigh the evidence that we have and being able to extrapolate from the evidence that we have around how teens have been impacted on other drugs of abuse, things that we're familiar familiar with, like nicotine and alcohol, even though because it's been a Schedule I substance, we don't always, we have not had all the data that we might want to. And really just looking at kids as a very different population. So I really appreciate all of yours perspectives and your wishes, and wish we could grant them. But really, really thank you all for your participation and your insights today. I'll turn it back over to Radha.
Great. Again, thank you so much for joining us today. Thank you to our fantastic panelists and for our participants for joining and posing some great questions here in the Q&A. The recording of this conversation will be available to view tomorrow on PolicyLab's website, which is policylab.chop.edu. If you like today's conversation, please do follow PolicyLab on Twitter and LinkedIn, or visit our website to find innovative research and engaging discussions on important public health topics. And also keep an eye out on your inbox. We'll be emailing a recording of this event and some links to relevant blog posts and resources. Thank you very much for joining us today.